Welcome to the February 1st, 2023 Standard of Care Ad Hoc Committee meeting of the California State Board of Pharmacy. My name is Sang Oh, chairperson of the committee. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. This meeting is being conducted consistent with the provisions of Government Code Section 11133. Participants watching the webcast will only be able to observe the meeting. Information and instructions are posted on our website. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allot 3 minutes to each individual providing comments. This approach is necessary to facilitate this meeting and to ensure the committee has the opportunity to complete its necessary business. I'd like to ask staff moderating the meeting to provide general instructions to members of the public participating via WebEx. Moderator?
Thank you, Mr. Chair. Before we get started, I would like to remind committee members and senior staff who are not speaking to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will interject with a brief friendly reminder or simply mute the microphone. To facilitate public comment, we will be utilizing the WebEx question and answer feature, also referred to as the Q&A panel. When the committee reaches a point in the agenda at which public comment is appropriate, public comment will be requested. Please note that the Q&A feature is not to be used, or is to be used only as a means for members of the public to represent that they would like to make a verbal comment. Once given permission to unmute, the member of the public may unmute themselves and verbally state their comment. The Q&A feature is not to be used for typing out questions or for committee members to communicate with one another. And with that, I return the floor back to you, Mr. Chair.
Thank you, Tricia. I'd like to take a roll call to establish a quorum. Members, as I call your name, please remember to open your line before speaking. Maria Serpa?
Licensee member present.
Good morning, Maria. Renee?
Good morning, licensee member present.
Thank you, Renee. Indira, Cameron Banks? I think Indira may not be joining us. Jesse Crowley?
Licensee member present.
Morning, Jesse. Nicole Tebow?
Licensee member present.
Good morning, Nicole, and I am here. A quorum has been established. As we get started today, I'd like to first say thank you to everyone that has been involved in this work. I truly appreciate all of the time members and stakeholders have dedicated to this topic. I believe we have learned so much from each other, have shared ideas and different perspectives. As we continue our discussion today, I ask everyone participating today to be respectful of the work before the committee. We encourage participation by members of the public throughout our meeting at appropriate times. The committee respectfully requests that when comments are provided, they are done so in a professional manner, consistent with how the committee conducts its business. I will now open the meeting for public comments for items not on the agenda. I'd like to remind members of the public that you're not required to identify yourself, but may do so. I would also like to remind everyone that the committee cannot take action on these items except to decide whether to place an item on a future agenda. Members, following public comments for this agenda item, I'll ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Moderator, we are ready for public comment for individuals participating via WebEx.
Thank you, Mr. Chair. I have opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists. Or you may simply raise your hand. For those of you who have called into the meeting, you may raise your hand by pressing *3. We are displaying instructions and will give you a moment. All right, I see no request for comment at this time. Shall I close the Q&A panel?
Yes, please. Thank you.
Welcome.
Moving on to the next agenda item 3, continuation consideration, discussion and consideration and approval of draft committee meeting minutes included in the meeting materials or draft minutes for the 2 meetings. We'll take them in the order included on the agenda. First, I will ask for questions or comments on the draft minutes from the October 25th, 2022 meeting. And when you speak, if you could just, Maria, go ahead, Maria.
Hi, good morning. Thank you. I just have a slight change to page 16. My comments on page 16, I think it's the first paragraph. Oh, no, it is in the third paragraph, sorry. It says, Dr. Serper wondered if the continuing education may be needed with standard of care. And I think the word additional is missing there. We were talking about the added CEs, not all CE.
Okay.
Thank you.
With that amendment, would you be willing to make a motion, Maria?
With that amendment, I move for acceptance of the October 25th meeting minutes.
Thank you, Maria. And any other members second or any other comments before?
I'll second that.
Thank you, Renee. Appreciate it. All right. Any other member comments? Moving along, we'll go for the public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel. If any member of the public would like to comment on agenda item 3, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see no request for comment. Shall I close the Q&A panel?
Yes, please. Thank you so much.
Welcome.
The motion and second and public comment, we'll go for the vote. Maria, how do you vote?
Yes.
Thank you, Maria. Renee, how do you vote?
Yes.
Thank you, Renee. Jesse, how do you vote?
Yes.
Thank you, Jesse. And Nicole, how do you vote?
Yes.
Thank you, Nicole. All right, next for our consideration is, I vote yes and the motion passes. And next for our consideration is the draft minutes from the November 16th, 2022 meeting. Members welcome your comments and also would entertain a motion to approve the minutes if you believe such action is appropriate. Members? Anyone have any comments or any motion?
This is Nicole. I'll motion to approve the minutes.
Thank you, Nicole. Anyone second?
I can second that.
Thank you, Renee. I appreciate that. All right, with a motion and second, we'll go for public comment.
Thank you, Mr. Chair. Again, I'm opening up the Q&A panel. If any member of the public would like to comment on this agenda item, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see no request for comment. Shall I close the Q&A panel?
Yes, please. Thank you,
Okay.
Tricia. With that motion and second and public comment, we'll go for the vote. Maria, how do you vote?
Yes.
Thank you, Maria. Renee, how do you vote?
Yes.
Thank you, Jesse. How do you vote?
Yes.
Thank you, Jesse. And Nicole, how do you vote?
Yes.
Thank you, Nicole. And I vote yes, the motion passes. Moving on to the agenda item 4, discussion and consideration of draft legislative report regarding assessment of the standard of care enforcement model and the practice of pharmacy. Since March of last year, we have received presentations, learned about actions taken in other jurisdictions, reviewed research, surveyed pharmacists, and considered policy questions. As I stated in my opening remarks, I truly appreciate everyone's participation in this process. As we begin our review of the draft report, I want to acknowledge that for some, this report may seem to go far, and for others, not far enough. Today, we'll be considering the draft, which is the starting place for our review. I intend to open up for public comment throughout the meeting, throughout this discussion of the draft report, as we discuss the various portions of the report. Thank you to those individuals that provided written comments. Your comments have been disseminated to members and posted on the board's website. Members, before I go on to each section and the process, do you have any questions before we begin? All right. And let me start here. Do you have, let me, here we, all right, there we go. Thank you, Tricia. Starting with background and pharmacy profession section on the report. Any member comments on that? just feel free to raise your hand. None? Okay, all right. With that, we'll go for public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel. If any member of the public would like to comment on this agenda item, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or you may simply raise your hand. We'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you so much. All right. And we'll open up members. Any comments on the committee process sections?
I'm sorry, Sung. Going back to background, I apologize.
That's okay. Absolutely. No problem. Go ahead, Maria.
Apologize. I'd forgotten I'd circled a word that I just think a different word could be used, and perhaps that could be done by the chair and the EO, where it talks about involving in the distribution, storage, and dispensation of prescription drugs. I think dispensation is the wrong word. Maybe it means dispensing, but
Could you point out which? Oh, I see. Storage and dispensation. It's probably supposed to be dispensing, is my guess. Good catch, Maria. Thank you so much.
again, I'm sorry I didn't bring it up earlier.
That's okay. You got that, Ann? I think dispensing, I think that's yeah. So that's good. Thank you. Do we have to open up for public comment again? And Arlene?
I don't believe so, because we're not taking action at this time. This is just comments on a draft. So I think we're okay.
Got it. All right. We'll move along. Thank you, Maria. And we'll jump to the committee process section. Lots of presentations on there. So I would imagine that we might get some comment. But any other member comments? Okay. All right, moderator, open the line for committee process section of this report. If we're just going along the report and reviewing it and getting public comments, member comments and public comments.
Great, thank you, Mr. Chair. I've opened up the Q&A panel, and if any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. We're displaying instructions and we'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please, Tricia. And then
Okay.
I'm going to also then go to the presentations portion. And so any member comments on the presentations? This is probably more for public comments. Oh, Jesse, go ahead.
Hi, Sung. Under the section that is for the presentation for the Department of Consumer Affairs, I think this is page 4, maybe the last, let me see which paragraph it is. Oh, it's the second paragraph, the last sentence there. It says in contract, section J authorizes the board. I think that may be a typo. I think it's supposed to be in contrast.
Yep. Great catch. That's why a lot of eyes makes a difference, because obviously all of us try to catch all that, but great catch, Jesse. Thank you. Any other thoughts? All right, we'll go for public comments. Reminder for public comment, this is for the presentation. So anything that we wrote there that was your presentation that you feel like could be changed or added on, and go ahead.
Should it be appropriate? One of the sets of comments that we received was from Dr. Chen, and he has requested some updates to the portion of his presentation. So if members are agreeable, staff will go ahead and incorporate the edits that he requested to the presentation that he provided. He did also recommend changes to a presentation made by another presenter I don't know that it's appropriate to just make that change, but if the committee is agreeable, staff will reach out to the presenter and make sure to determine if the report is appropriate or if modifications should be made. I just wanted to close the loop on that if that's if the committee is agreeable with that approach.
I would say absolutely, but make sure that members feel good. So, everyone agreement? Okay. All right.
Wait, just for clarification, Sung, sorry, this is Jessie. We're referring to, I guess, just the changes to Dr. Chen's presentation initially, and then the executive officer will reach out to the other presenter about the other proposed changes. Is that right?
If they have any, yeah, just confirming if there's any clarification or changes. Because I think other comments weren't about their presentation. They were just comments about global
Right.
standard
Okay.
care. But I think Dr. Chen specifically pointed out a few things on his portion that he wants to make clarification.
Okay. Thank you.
All right. We'll go for public comment.
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or simply raise your hand. We are displaying instructions, and we'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Sure. Yes, please, Tricia.
Okay.
Then moving on to the next portion, information and other jurisdictions. Any comments or questions, member? Seeing none, we'll go for, I think, Jessie, your hand is up, but it's for last one, right? Okay.
Sorry, I always forget to put it down.
No worries. No worries. All right, so we'll go for public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel. Members of the public may type comment and submit it to us, or simply raise their hand. We're displaying instructions. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia. Next is the research reviewed section, including articles, opinions, and published research provided for consideration. The list seems to be complete for me, but I will welcome any other comments. Okay, seeing none, we'll go for public comment.
All right, I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen, or simply raise your hand. We'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia.
Welcome.
All right, moving on to the survey results portion of this report. Members, any thoughts on it? Survey results was just kind of the survey we did when we were rolling out this committee. So it summarizes it. I don't think attachment need to be provided, because it can be provided if they need it. Any thoughts? All right, we're ready for public comments.
Thank you, Mr. Chair. I'm opening up the Q&A panel. Any member of the public that wishes to comment can type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. We'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia.
You're welcome.
All right. Next portion is a little bit more, we might take our more time if members would like, or public comments desires, but the policy questions, so the intent of our discussion today is not to rediscuss the issue. You're more than welcome to add comments, but to confirm if the summary is accurate, and also if anyone has any other thoughts. So members? We're getting to the meat of the report. Maria?
I'd like to start with some format kind of issues. I'd like how the first two policy questions call out facilities. I think that's very helpful to break up the discussion. I would suggest that the third and the fourth question also bold the sections that call out pharmacy personnel excluding pharmacists and pharmacists in the following question. I think that would make it helpful to target the concepts for each of those questions in the beginning. And then I have a lot of discussion towards the end, but I'll wait for others.
Okay. Anyone else before Maria jumps in? Maria, the mic is yours.
Oh my goodness, such pressure. We are not going over one question at a time. It's all the questions. Is that correct?
Yeah, I believe that's sufficient.
So,
yeah.
The third from the end question, does the board believe steps are needed to ensure pharmacists have sufficient autonomy versus corporate policies? The answer there is very, very short, and I'd like to suggest some additional wording to make it more clear. So I'm not sure if I should just read it or if we have a way of showing it. If not, I'll just read it.
Yeah, go ahead and we chose not to do screen share.
That's fine. That's okay. I'm sorry. I didn't mean to cause confusion with the moderator. The answer says pharmacists must have autonomy to treat patients, which is a nice global statement. And rather than having a whole discussion in here, I was thinking that just adding some more words would be helpful. To say autonomy to treat patients, clinical care within their expertise and judgment. Because we did talk about corporate policies for process, for paperwork, for documentation. And so I wanted to make sure that those were two different subjects, that the autonomy is about the clinical care of patients within their expertise and judgment.
That sounds good to me. I would agree to add that portion. And
I have one other comment, but I'm not sure if you wanted to do one at a time or.
Go ahead. Yeah.
Okay. The other one is the one that's like the bigger one. It's like huge. It may cause a lot of public comment. Okay.
It's okay. That's why we're here.
The second from the last question, which is the little warning signal that I see in the background of our discussion about the prohibition of corporate practice of medicine and whether that should be similar in pharmacy. I think the answer is accurate and correct, but I would hope that we would add some more language in there to have it be a more robust discussion, because any prohibition of pharmacy corporate practice would be a serious change in the practice of pharmacy, access, some legal and business issues. I mean, there's a lot of things in there. So I think that some language would be helpful to include on there about what that means. If we were to look at prohibition of pharmacy corporate practice, what does the current corporate practice look like in our state? Are there other states that do this? I don't think there are. And then also, would we be able, there would be some legal questions about that. Would we be able to do that? And then even if we were able to do that, just looking at the kind of like crystal ball of what pharmacy would look like if we didn't have corporate pharmacy, it would be significantly different and may take years, if not decades, to change to that point. So that's a little warning signal I hear in the background. I just think we need to at least address it. Maybe not into that detail, but address that there are some big warnings about if we're looking at changing corporate pharmacy. That's a big issue in itself. Thank you.
Thank you, Maria. And you got all that right. I'm gonna rely on you. Okay. All right. Jessie?
Thank you, Sung. Getting to Maria's first point with the autonomy, I think that question was initially getting at the comments we received from pharmacists, specifically in chain community settings, where they felt that some corporate policies and procedures may have prohibited them from being able to provide appropriate patient care in certain scenarios. I do agree that there needs to be some more clarification and a more thorough response in the answer section. And I'm wondering also for that second part about the prohibition of corporate practice of pharmacy, if maybe we can include some statistics about the percentage of pharmacies within California that are corporately owned, just to give more perspective on how difficult that transition would be. That may be appropriate if other people agree.
Sounds good. Any other thoughts? All right. Go ahead, Nicole.
This is Nicole. I was just going to jump in and say, just for clarification for me, it was kind of my understanding that the second point that we're talking about, that the corporations, it's not so much saying that corporations cannot exist and cannot run pharmacies, but very specifically, they can't set the specific care that you're giving to the patient. And I think that's maybe getting a little conflated at times. So yeah, they can say we're going to have a vaccine program, but they can't say this is the vaccine you give to this specific patient. That has to be the discretionary part. So I understand where some of our hesitation comes from, but I think that the concept is very sound behind that.
Right. I think that that I'll just add a little comment and I'll go to you, Maria. I think vaccine practice is a good example. Like, I think that corporate practice may say like, oh, you just need to screen people as fast as you can and just give. But that should not be the practice of, it should be that pharmacists really needs to consult a patient and try to make sure that they're appropriately, eligible for whatever it is. And it shouldn't just be a checklist. It should be a pharmacist providing that care and, following standard of care. So, that's your great point, Nicole. Maria?
Yeah, just to follow up on Nicole's comment, I totally agree with her if that were very clear on here. But the problem is when you're considering or relating it to the corporate practice of medicine, that is very specific and different. And I think that maybe some people, members of the public that work for Kaiser or other large healthcare organizations, can explain how their physicians are separate and not contained under the Kaiser corporate umbrella because of this law, which they have to be totally corporately owned separately. I don't know what it all is, because all I know is it from a layperson's point of view, but it's huge. And so if we're not considering that, I think that would be much easier and more clear. And so I agree that Nicole's comments are probably our intent. We just have to word the question maybe differently to make that clear. Otherwise, it's almost too big of an elephant to swallow.
Okay. Jesse?
I think maybe we should expand on it then to make it clear the corporate ownership versus the corporate practice of pharmacy. I'm not sure that you can necessarily separate the two, because ultimately a corporate can make their own decisions on what they want their pharmacists to do. But if there's a way to kind of word it so that we're saying something along the lines of like corporate policies and procedures can't contradict what guidance is, but I guess that's the whole concept of standard of care. I don't know how we completely separate the two, but if there's a way that maybe you and Anne and the staff can work on the language to just make it more clear, I think that would be helpful.
Okay. All right. Anne, I'm sorry to put you on the spot. Could you just summarize a little bit of an update we might be having, or do you want to do that maybe after so that we could have something for next meeting? Which would be, I have also someone raise their hand. We'll definitely go to public comment, but
Yeah,
We can-
so so we have the formatting changes, and then with respect to the question about autonomy, we're going to flesh that out a little bit more to link that back to the clinical care specific with their expertise and judgment. And then specific to this question, we're going to refine the question a little bit more to potentially provide more context with respect to what we're talking about, with respect to the prohibition that we're specifically talking about, and then link it more specifically to not the ownership per se, but really linking it back to the
Okay. All right. Sounds good. Members, we're going to go to public comment, but I'm sure we're going to talk more on this a little bit more. So we'll come back, I'm sure, to hash out just a little more. So we'll go to public comment. I see Dr. Shane is already there. So
that's right. So any other members of the public that wish to comment, please type comment using the field in the lower right-hand corner of your screen, or simply raise your hand. There is a 3-minute time limit. I'll give a 10-second warning. And Rita, you should be able to unmute yourself.
Tricia, just for the sake of this is such a big portion of it. Even though it's 3 minutes, I'm going to allow people to re-queue just so that they can, just because I need to make sure that everyone's thoughts are represented in this report.
Okay, so if they get cut off, they can get back in line.
Or right? Yeah, that's fine.
Okay, perfect. Rita, you're unmuted.
Oh, thank you. This will be short. This is Rita Shane, Vice President, Chief Pharmacy Officer at Cedars-Sinai Medical Center. I suppose we could be considered a corporation as well. I suppose we are. I never think about it that way. But that being said, I think perhaps something along the lines, and again, I'm wordsmithing, would be that corporations cannot define the practice of pharmacy. Or delineate the practice of pharmacy. That needs to be done within the scope of what a pharmacist can do. So something along the lines of that, because there really is a line in the sand with respect to what a corporation can do, where they determine that they're going to have a pharmacy to care for their population of patients or consumers, but they cannot define the practice of pharmacy. So.
Great point, Dr. Shane. Tricia, are you there?
Sorry about that. I'm so sorry. Keith, Keith Yoshizuka, you should be able to unmute yourself. Let me try that. Oh, there you go. You're unmuted.
California Society of Health System Pharmacists. While I understand the concern about and the legitimate concern about prohibitions against the corporate practice of pharmacy and medicine, I did want to suggest that the wording be crafted carefully, because there should not be a prohibition against adoption of standardized protocols. Because if that were the case, then the state of California would be practicing pharmacy and practicing medicine for establishing the guidelines that pharmacists have been using for the last 20 years. So I want to make sure that it doesn't include, development of protocols, and I guess it'd be better to call them guidelines, because guidelines are recommendations, but under certain clinical circumstances may be deviated from. Thank you.
Thank you, Dr. Yoshizuka.
Next, we have comment from Stephen Gray. Stephen, I'll let you know when you can unmute yourself. All right, Stephen, you should be able to unmute yourself. And you're unmuted.
Thank you very much. This is a very, very important discussion, and I really appreciate the extra time that commenters are given, both by board members and the re-comments, et cetera. First of all, just a process comment. I suggest strongly that when you have in the report or in any document that the questions be numbered. This will help the legislature as they review it and the public when they have questions, and it'll make it a lot easier to be sure that we're directing comments and others can view it. So please number the questions when you go to the report, and et cetera. The second thing is I had worked for Kaiser Permanente for 46 plus years, and it was very important for people in pharmacy operations to understand the difference between the medical group and their activities and authorities under the corporate practice of medicine law versus other healthcare providers such as pharmacists, which were really employees. And I use that word very carefully because that's the essence of the corporate practice of medicine law, which actually should be called the anti-corporate practice of medicine law, where physicians in California, with a couple of exceptions, cannot be employees of a corporation, of a partnership, of another business. They are contractors. And the essence between contractors and employees is contractors are engaged in a contract to provide, in general terms, a certain service or a certain responsibilities, etc. Employees can be directed on how to do that. So that's the essence of what we're talking about and the difference there. The corporate practice of medicine, as I called it, corporate practice of medicine law is kind of unique to California. There aren't many other states that have something that inhibits physicians. It's also misnamed because, as I mentioned, it doesn't just apply to corporations. If you have a pharmacy owner that is not a corporation, but it's a partnership or et cetera, they also fall into that category. They should not be allowed to define. However, it was very important that they have the corporations, the business owner for the pharmacy or for a clinical practice, which can be owned by someone other than a pharmacist, a clinic, for an example, et cetera. They should have the right to decide what business they're in or what services they provide. And as Dr. Yoshishida indicated, they may have certain ways of doing things that are a little bit more than, there are guidelines or et cetera.
10 seconds.
So I would encourage you to take that into consideration and make sure that you understand that it's more than just corporations. Thank you.
All right. Our next comment is from Susan Vanilla. Susan, you should be able to unmute yourself.
Susan Bonilla, the CEO for the California Pharmacists Association. Again, I do want to thank the entire committee and President O for this discussion. And my suggestion might be that this is such a complex issue that there might be a need for a meeting that kind of dedicated to digging into it a little bit. My recommendation, given the language that we have before us now, is to maybe consider the concept of corporate interference being what is really the intention here of prohibiting corporate interference in the actual practice of pharmacy by the pharmacists themselves. So that would just be my one comment that might help clarify the current discussion, but I do encourage us to maybe continue this discussion because I do think it really deserves the time and consideration of a thorough overview because I do think there are some benefits here that are worthy of being considered, but again, probably not in the context of this specific report. Thank you so much.
Thank you, Susan.
Next, we have Clint Hopkins. Hopkins, you should be able to unmute yourself.
PharmD, owner of Pucci's Pharmacy. And I just wanted to jump in and comment that when we say corporation, all pharmacies are corporations, whether we're an individual corporation or a multi-store corporation or a chain corporation. And I'm not keen on the wording of just saying corporation. I think we really, if we're going to try to do something here, we really need to define exactly what corporations we're trying to define. Thank you.
Thank you, Dr. Hopkins.
Next, we have comment from John Gray. John, you should be able to unmute yourself.
Hi, good morning. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. Thanks for the opportunity to provide just some very brief comments. We appreciate the concerns that Board Member Serpa flagged about the question related to the corporate practice of pharmacy. And we also appreciate the direction that the committee is taking to further refine the question and its answer to this question. Hopefully, I think one way to look at it would be, rather than linking the committee's answer to this question to the Corporate Practice of Medicine Act being very precise in stating, what exactly this committee and this board is recommending on this issue, because as other commenters have pointed out, the Corporate Practice of Medicine Act in California is very expansive, and so we would suggest considering decoupling the discussion of this from the Corporate Practice of Medicine Act, because it sounds like even among committee members that may not be really what the committee is envisioning. Thank you so much for the opportunity to provide comments this morning.
Thank you, Dr. Gray.
All right, the next request for comment is from Andre Pieters. Andre, you should be able to unmute yourself. And you're unmuted.
Okay, good morning. Andre Pieters. I'm a director of pharmacy with Sutter Health. I think we have to also keep in mind, as we're having a discussion on corporations, that in a health system, which is ultimately a large corporation, usually not for profit, but could be otherwise, that I know we derive a lot of strength in having subject matter experts, both at health system level, health system office level, as well as local at our hospital levels. And there is a lot of us getting together, and let's say we want to develop evidence-based guidelines on, for example, antibiotic stewardship, that we can come together under the umbrella of the health system, or i.e. the corporation, and look at the latest evidence and develop evidence-based guidelines, as for example, for community or hospital-acquired pneumonia. And I think we have to be careful not to cut off the hands of a corporation to allow for that sort of collaboration, where we're going to get together and then develop guidelines that we can push out for adoption to local practicing pharmacists at the hospital level. Another thing that I want for us to keep in mind is that unlike physicians, pharmacists are employees of corporations or business structures. And we have to be mindful that there could be pharmacists practicing possibly outside of the scope of their practice. And then this is just a scenario where maybe the corporation needs to step in and identify that this could be a possible problem for us, and it's creating a risk for the corporation. I think we're all well aware that we live in a society where litigation is plentiful. And that litigation usually goes for the structure with the deepest pockets, and in this case, the corporation. So again, I think we have to be mindful not to cut off the hands of the corporation, to limit the liability
10 seconds.
of the company as well. I'll end for right here and possibly requeue for something else. Thank you.
Thank you,
All
Andre.
right. Our next request is from Paige Talley. Paige, you should be able to unmute yourself. There you go.
Paige Talley with the California Council for the Advancement of Pharmacy. And I just wanted to comment that I agree with Dr. Hopkins from Pucci's Pharmacy that all pharmacies are typically incorporated, and there needs to be some further definition on what you mean by corporation. Thank you.
All right, this is the moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yeah, sure. Just make sure that no one else is re-queued or anything. And I'm sure we'll have some discussion among board members. Okay, go ahead, Tricia.
Okay, it's closed.
All right. All right. Okay, we got a lot to talk about. So Nicole, you raise your hand first. So go ahead, Nicole.
Sure, thank you. That was a great discussion. I don't think I can appropriately say who said what thing, but thank you all for your comments. Number one, yes, can we please number the questions?
Yes,
That would actually make it a lot easier.
I was gonna bring that up too. Thank you, Nicole. Yeah.
I thought that one was great. I really liked the suggestion as well of using the word interference from corporations. I think that's a great recommendation, especially when you look at Dr. Hopkins' point that most pharmacies are corporations. And when you're looking at an individually owned, where a pharmacist is both the owner and the PIC and the pharmacist, we would get into some situations. I think what I ultimately took from this discussion, though, is this is a larger issue that we need to discuss more. So I wanted to propose either maybe another subcommittee or a continuation of this one that could specifically look at this issue. I don't know what way we could do it, but that would be my proposal.
Thank you, Nicole. Maria?
Hi, thank you. I really did appreciate all of the comments because it also caused me to think about how, even though they seem to be related to the corporate practice of pharmacy, how we have some opportunity to improve the question above it about the pharmacist's autonomy, that we need to include some language about scope of practice to assure that it's within the scope of practice that is authorized, not just within their perceived expertise or judgment. And also something about pharmacists working in collaboration to form guidelines that are done in collaboration with their coworkers or their corporate entity or something. That should not be something that we provide any barriers to the optimization of patient care that can be seen by collaboration. That you don't have a rogue pharmacist deciding, well, I don't really care what the system, the subject matter experts say, I believe this, and go off on their own track. So I would just include those kinds of comments in the pharmacist autonomy section also. Thank you.
Thank you, Maria. Any other thoughts?
I just wanted to say, I certainly appreciate so many comments and all the great minds that are going into thinking about how to optimize this process for patient safety. And I would pretty much agree with, second everything Nicole said. I think the wording of perhaps interference really helps define what we're trying to avoid. But that, I think, like everybody mentioned, this use of the word corporate is, it's a legal term. It's also just kind of an overall idea of sort of non-pharmacy interference. So I think really spelling that all out, I'm certainly not an expert in all the definitions when we refer to corporate. So, however we can have a better discussion and really get to a really accurate definition, I think would be really beneficial.
Thank you, Renee. Nicole?
Sorry, just wanted to clarify, was my suggestion that we continue this or create a separate committee? I don't mean for that to stop this work from moving forward. Just wanted to clarify that. I think we can still move forward with this and then separately, as an addendum, work on this while this work is happening beyond us. Sorry, just wanted to clarify.
Thank you, Nicole. And you were talking about the corporate practice of pharmacy in general. I mean, I'm not trying to...
Yeah,
okay.
my thought was that we could put this in here, we need to do something about corporate practice of pharmacy, let it go with a slightly more broad statement with the idea that we'll continue that work after, while the legislature is doing its work with our recommendation, so that we don't hold up the process. That was my thought.
Right. Yeah. Okay. Thank you, Nicole. Yeah. We have a deadline, which is July, so we have to finalize this report in some ways. Jessie?
Hi, thank you, Sung. Just one comment in regards to, I think there was a lot of comments, I forget from who, but essentially just discussing about a corporation, for example, a hospital being able to collaborate and set their own guidance for certain things. And I just want to be sure that I think my impression is as a board, we just want to make sure that any guidelines or protocols don't contradict what has been set by like national standards, for example. I think that's kind of the gist and the core of what we're getting at is anything that could potentially compromise patient safety or things that are outside of like the guidance or guidelines. And that's actually another point. I remember at a previous discussion, and I think it was in regards to the HIV PEP and PrEP for furnishing by pharmacists. There was a presenter, I believe, who said that the term guidelines actually created some issues because there are some updates that are considered, quote, guidance for certain things. And so they ran into issues where the legislation and the statute as it exists actually makes it difficult to get the most up-to-date guidance that's set by national standards. So that's just something to keep in mind maybe when we're thinking of the correct term to use for guidelines versus guidance, or maybe we should have a continued discussion on this as well, just thinking of the correct wording so that we don't have to, update things later.
Thank you, Jessie. Yeah, I mean, it is challenging to just say corporations. So Dr. Hopkins bring a great point. We really probably have to drill down what are we trying to say here. So with that, I think it's a good opportunity for us to open up for public comment one more time to make sure that anyone wants to say anything could voice their opinions.
All right, this is the moderator, and we've opened up the Q&A panel again. So if any member would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and send it to all panelists, or simply raise your hand and we'll give you a moment. All right, and we have Stephen Gray asking to comment. So Stephen, I'll let you know when you can unmute yourself. And Stephen, you should be able to unmute yourself.
Thank you very much. To elaborate a little bit on my earlier comments, in the statutes already, there is a recognition of the ability of employers of pharmacists to set policies, procedures, and guidelines. For an example, in BPC 4052.1, which is all about facilities and hospitals, it specifically says there that the hospital has the ability to, determine the qualifications and privileges of the pharmacist that it employs, and also, but that also needs to have the approval of the hospital administrator. So it's a little different than with a physician, which is qualifications and privileges by the medical staff, and it's a little bit different, again, because the pharmacists are usually employees. Likewise, in 4052.2, it grants the same privileges, the same authorities to health plans. If you read it very carefully, their collaborative practice acts can be established by the health plan. And so we need to recognize that difference. Further, there are corporations of pharmacists. In other words, in California, there exist professional corporations. For an example, a medical professional corporation, which is physicians, the shareholders have to be at least the majority of shareholders, but the shareholders can also be pharmacists and others. And pharmacists can have their own professional corporation. So again, it gets back to being very careful with the wording, understanding the difference between a contract and what is authorized and how much control has existed over someone who's working under a contract versus an employee. And so I applaud the comments that say we need to discuss this and be careful, because as mentioned by Maria Serpa and others on the board, pharmacists who are leaders in their profession really can establish things that are on the front lines of standard of practice. It isn't necessarily what all pharmacists agree to and do, and they make decisions, for an example, whether they're going to go to work for a hospital that has certain policies, procedures, and is in certain services and businesses, and they may reject those. They should not have the right then to use the law to go in and say, well, like it was mentioned, I don't care what the employer says. This is what I'm going to do, and this is the services. These are the services I'm going to provide or not provide. So I applaud. We need more discussion on this going forward. Thank you.
Thank you, Dr. Gray.
All right, the next request for comment is from Daniel Robinson. Daniel, you should be able to unmute yourself. There you go.
One of the questions was dealt with setting minimum requirements for training and education appropriate to ensure baseline competencies. And I just want to point out that the board already does that. The board works closely with the Accreditation Council for Pharmacy Education, with NABP, with California schools and colleges of pharmacy. And the PharmD education is that entry-level standard, and it's standardized across the United States. Post-PharmD education and training is really handled nationally through through a residency accreditation process, through boards of pharmacy specialties and other professional certifying bodies. So what I would suggest, if you look at the medical model, where they have 40 specialties and 87 subspecialties for the practice of medicine, that's controlled by the American Board of Medical Specialties. And the medical board of California is not involved in setting requirements for education and training beyond the PharmD and the DO degrees. So I would suggest that we allow the profession and accrediting and certifying bodies to be setting the standards and qualifications beyond our entry-level degrees. So that probably should not be the role of the Board of Pharmacy. And also, I'm hoping that there will be an opportunity to comment on it's a general statement about the overall report at the end.
Sure.
Thank you.
All right.
Thank you so much.
This is the moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia. With that, members, are we ready to move on? Any other thoughts? Okay, we're moving on. Members, we're going to do recommendation. I thought this was going to be a little bit more fun. So let's see. This for me is really important to hear your thoughts, because this little sentence I feel like is a little meat of the report. So I agree with the recommendations as presented, and I'm open to hear more about it. But I do believe the board should evaluate and work to repeal some prescriptive conditions. So, Jessie?
Thank you, President O. I agree. I thought the recommendation section really was concise and captured, I think, the robust discussions pretty succinctly. And I think it reflects our discussions pretty accurately. So I'm sure this will be an ongoing discussion, and especially in the last part when we talk about the transition to a standard of care model for certain things like patient care services. So that will be an important ongoing discussion.
Thank you, Jessie. I would just recommend to everyone that just look at it as a totality of recommendation, not just one sentence or the other. Maria?
I also agree. I thought it was a very concise, actually a lot shorter than I would have thought for such a very complex topic. And I really appreciate the effort that went into make that concise. My only comment is I find it confusing to me, and I'm wondering if it would be to the to non-pharmacy people, legislature, for example. Maybe we need a definition section, because the beginning we talk about standards and care enforcement model and hybrid, and then we talk about standard of care model for the provisions of patient care. And those are all different. And I think a lot of times that we have heard during the public comment that people are referring to one and not the other. And so that would be my only comment, is that we have some sort of definition, or maybe another
glossary
in here that talks about what is the standard of care patient care model versus the standard of care enforcement model. Mm-hmm. And how is that the hybrid? That would be my question. Thank you.
Thank you, Maria. Other thoughts, members, before we open up for public comment? I'm sure we'll get quite a few public comment on this. Hi, Renee, go ahead.
I think this is a very succinct wording. I'll be interested in the comments. Since the board has the mandate of patient safety as well as consumer affairs, I thought that somewhere in here would refer to the fact that what's also been evaluated with all this is patient safety. Because I mean, in there it says there's safeguards to ensure pharmacists maintain autonomy. And so we are talking about, increased quality of care for patients ultimately, but we also have balanced it with thinking about patient safety. So I don't know where I would add it in there or what anybody else thinks about that. But I think that might be worth being able to include.
Yes, yeah, absolutely. Great point, Renee. I'm sure Anne over there is frantically taking notes from our discussion. I'm sorry, Anne. Thank you. All right, Nicole, no thoughts for now? Since everyone has spoken.
It was really well written. I think the staff did a great job. So.
Thank you. All right, great. We'll open up for public comment and we'll come back. All right.
Thank you, Mr. Chair. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen, or simply raise your hand. If you've called into the meeting, just press *3 to raise your hand. We are displaying instructions and we'll give you a moment. I do see that Daniel Robinson has a request for comment. So Daniel, you should be able to yourself.
Thank you. And I want to thank Dr. Serpa for raising the question about a definition. I really believe the report needs to start with a definition of standard of care so that everything else sort of fits within the framework that we're discussing. As you look at the report right now, definitions are provided in several of the presentations. And as I looked at those definitions, the focus really is on patient care. And it's not, if there's a clear violation of the law, regulations, or statutes, the Attorney General's office and the Department of Consumer Affairs suggested that that's a violation of standard of care. Well, that's a violation of law, and that's something that the board already effectively handles and deals with. What we're talking about here is in the delivery of patient care. We need a definition that talks about the standard of care that should be expected of any practitioner providing a certain activity or a patient care service, and how that will be dealt with in a regulatory process. So I would hope we can. The board can move, or the committee can move a definition to the beginning of the report so that it's clear to everybody reading what the context is. Thank you.
Thank you for the comment.
All right, the next request for comment is from Susan Bonilla. And Susan, you should be able to unmute yourself.
Thank you so much. And again, I do want to express my thanks for the thoughtfulness that's been given to this. My one suggestion with the recommendation would be to consider perhaps including some next steps. I think that upon reading the report, the legislature might be curious as to what the board is considering in terms of actually then moving their recommendations forward. I think that it would be perhaps a good idea to indicate that the ad hoc committee was going to continue to meet to then actually act upon the recommendations. You might want to continue a mention of your process that includes the stakeholders that has been going so well. And I want to thank you for the inclusiveness of your process. And then you might want to consider a timeline. I think leaving it open-ended might cause some questions with the legislature. They put a timeline on when the report was due, July of 23, and I think it would be very wise for the board to communicate the expectation of when some of these issues would be developed and then perhaps the changes made. So those would be my recommendations. I think that as we're dealing with, additional independent authority, the repeal of some prescriptive conditions and the ultimate transition, the question will be, how are you going to do it and when are you going to do it? So that would be something that I might recommend be included in the final draft of the report as one of the recommendations. Thank you so much.
Thank you, Susan.
All right, our next request for comment is from Stephen Gray. And Stephen, you should be able to unmute yourself.
Thank you again. I also agree. I really do like the way this paragraph for recommendations is general and written. I also agree with several of the suggestions. Law and understanding among people that work in any group or profession is always good to have a definition section so that we're talking about the same thing. One of the definitions, for an example, that's used across the country, which is sometimes synonymous with standard of care, but not always, is standard of practice. And is that people really thinking standard of practice, or are they thinking standard of care, and consider that. Also, the board, the legislature, the board has the right to set in law standards of practice. For an example, the board and the law require patient consultation on a prescription. It's not up to the business or the pharmacist whether they're going to do patient consultation or not. A good example of where it's super important is sterile compounding. Those are important parts about what a pharmacist should do and be responsible for. And they establish legally, especially for civil law, administrative law, the standard of practice, the standard of care. I also agree with the concept of moving forward and having a process, having deadlines, having next steps, as it was stated. And also to, have in the report, those definitions at the start. So as the legislators and their staff are reading it, they really understand, because they have different impressions of what we mean by certain terms also. So I really commend the staff on having a brief, but there are and well-written recommendation section, but it could be a little bit adjusted as these comments indicate. Thank you.
Thank you, Dr. Gray.
All right, this is a moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you. On the next steps, I think we just wanted to wait until how the discussion on our next agenda item goes, and then we will amend that part, and as well as timeline. Any other thoughts, members, after hearing some comments? All right, we're moving on to the next section. Just the acknowledgement. That one is probably going to be, anyone want to add anything? I think I think we didn't miss anyone. And just a reminder to, I really appreciate all the presenters and thank you for all the time that was spent on the last almost year or so in this committee. So any other thoughts, members, on the acknowledgements? And I just want to acknowledge Ann Sodogren here, who has spent countless nights and weekends on working on this. So thank you, Anne. Also, your name probably should be on there as well. All right. Moderator, open up for public comment.
Thank you, Mr. Chair. I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists. Or you may simply raise your hand. We will give you a moment. I do see that Susan Bonilla would like to comment. So Susan, you should be able to unmute yourself.
Thank you again so much. And I wanted to just share that we did do a survey of our members of the California Pharmacists Association. We want to always let them know what is happening and the progress that is being made. And I did want to share the survey result that we found that, and we had a robust response that 84.2% are in support of moving towards the standard of care enforcement model, knowing that this will have impacts on their practice of pharmacy. But I did want to share that we have been working to make sure that there is education, that there is building support, because I think as we are discussing these changes, we're also cognizant of the fact of communicating with the licensed pharmacists within the state of California that this is the movement we're taking. So I did want to share that survey result with you, that we believe there is strong support and that we believe as the process continues, one of our roles as the Association for Pharmacists is to continue the education, the conversation throughout the membership and the community of pharmacists. Thank you again so much.
Thank you, Susan.
All right, this is the moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please.
Okay.
All right, I appreciate everyone's input. I will work with staff to update the report with our discussion and some comments, and we'll consider it again our next meeting, at which time we'll probably need to finalize for board to review. And before I go, we'll just open up. Jessie, go ahead.
Hi, Chairperson O. So I just had a couple comments. I wasn't sure exactly where these fit in. This is in regards to the submitted public written comment, because there were a couple of amendments and clarification that I do agree with, but unfortunately it didn't go by section. So I just wanted to point them out individually. And this is from Dr. Stephen Chen's suggestion. So there was one portion, it says page 14, paragraph 2, that discusses the comprehensive medication management. And there's, right now as written, it says making sure the right medication is chosen for a patient's diagnosis at the right dose. Dr. Chen points out that that's part of a core responsibility of pharmacists, which I agree with. And then there's some language about how that can be clarified to actually to reflect what comprehensive medication management is versus what's part of standard practice for pharmacists. I agree with the suggestion that they have, the recommendation. And then I think there is a second one here that I have a note on. Let me see exactly where it is.
We're absolutely going to include Dr. Chan's comments under his presentations.
So this isn't part of his presentation. This is some of the comments in regards to just the language.
Oh, I see. Okay.
And then there was another one about, here we go, page 5, paragraph 4 of his letter, where it says, the standard of care may vary based on location or practice setting, creating different patient care standards for California patients. He has suggestions on how to clarify that more. And I agree with that recommendation to clarify it and make it more clear and concise, where he says, instead of creating different patient care standards for California patients, revising it to say something along the lines of is flexible depending on facts, circumstance, location, patient history, and patient compliance, state of emergency, and just including other sort of things that would be encompassed in standards of care. So I would be interested to see if there were any other board members that agree with his comments and suggestions on the things that are not listed under his presentation. So just those two items that I agree with. Changing the language.
Challenge with that one, Jesse, is that was presented by, I believe, DCA. So it's kind of like it's DCA's thoughts, and he may be not agreeing, but we have to make sure that the DCA would be okay to that, because I think
Okay.
Yeah, I was just presenting their presentation is my understanding. Please correct me, Ann, if I'm wrong, but so that's the challenge with that part.
Perfect. And then was that the same with I guess it is the same. Both of those comments were for under presentation.
Yes,
Okay.
yes. Yeah. That's a
Perfect.
challenge. Yeah. Thanks for bringing that up though.
No
Try
problem.
to see if there's a way that we could add that into somewhere so that there's another opinion of the other side. All right. Any other thoughts? Okay, I'm going to open up for public comment in the global report section. Just overall perspectives. Any other comments?
Thank you. Yes, I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. I do see we have Rita Shane raising her hand. Rita, you should be able to unmute yourself.
Yeah, thank you so much. So I would support Dr. Chen's thoughts on this. I think I had similar thoughts in the letter I wrote, because the practice is local based on the needs of the populations being served and all of the other factors that were just outlined that were addressed. And so I understand there might be a DCA related issue, but I do think we know that and I don't want to use the practice of medicine from a corporate perspective, but medicine is not the same depending on where the patient is being seen. And so I think if there is a way to put this in language that would enable standard of care to exist, however, it would be based on the needs of the specific patients and resources and the organization, with the organization's support under the auspices of the PIC, which is kind of, I'm jumping ahead, but I do believe that's a critical piece of this as well. Thank you.
Thank you, Dr. Shane.
All right, I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you so much. So we'll continue to work on it and we'll bring it back on our next meeting. Anne, go ahead.
Just from a process standpoint, aside from the formatting changes, is it easier for members if these changes are made in track changes so that you can see it, or easier just to make those changes and then reviewing it fresh? Just need to know what's the preference of the committee.
Track would be great for me.
I agree. Track changes would be way easier.
Yeah. Thank you, Anne. Thank you, everyone. All right, let's take a quick break here. It's 10:18. We'll take about a 10-minute break and we'll come back and finish. And so 10:30, we'll come back at 10:30 on next agenda item, on next steps. See you soon. All right, it's 10:30. We'll get back on it just to make sure everyone's back. We'll take a roll call really quick. Maria, are you back? Not yet.
Hi, I'm present.
Oh, hi, Maria. Welcome back. Renee, are you back?
I am back, present.
Thank you, Renee. Jesse?
I'm here.
Thank you, Jesse. Nicole? Thank you, Nicole, and I'm here. All right, let's get back on it. Moving on to the next agenda item 5, discussion and consideration of legislative proposal related to pharmacist scope of practice. Members, although not required in the legislation, it appears appropriate to consider if changes to authorized provisions for pharmacists is appropriate to facilitate a more robust standard of care practice model. Standard of care practice model. Any such change would require legislation. If the committee and the board agree, recommendations could be included as part of the report to the legislatures. I believe we could take a few different approaches by offering general content areas for change, themes of changes, or work to draft legislative language. The meeting materials provide policy questions for our consideration today. Let's get started. So first question, under current law, the scope of practice varies based in part on the practice setting. Pharmacists working in a healthcare setting may perform functions under BPC 4052.1 and 4052.2. Is it appropriate to include the authorities for all pharmacists? For me, I firmly believe it's time that we provide authorities for pharmacists where the workplace conditions are appropriate to support such activities, but does not hinder for certain practice settings. And it's time that all pharmacists should be given this opportunities. Open up for members. Your thoughts, please. I'm not going to call each of you. I'll just share. Anyone who feels strongly, please share your thoughts. The silence agreement, or is a silence disagreement? Anyone, any thoughts?
This is Renee. I would, kind of agree with what you said to expanding the authority to the practice settings. I mean, I think it's been discussed, some of the possible barriers, but that's not, again, should probably be considered separate. And all practice settings, but as was discussed, to exclude certain areas such as compounding. So.
Thank you, Renee. Any other thoughts? Okay, we'll go to public comment.
All right, this is moderator. I am opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and send it to all panelists, or you may simply raise your hand. And I do see Rita Shane has her hand up. Rita, you should be able to unmute yourself.
Hi. So, I was thinking about this, and again, I included in my letter, so apologies for the redundancy. So for things like sterile compounding or the Drug Supply Chain Security Act, where there are already national guidelines or recommendations, I know that the state board endeavored, in fact, the state board, I have the history, was probably one of the first in the country to recognize the importance of having a guidance to ensure safe sterile compounding based on what happened here in California. So we were actually way ahead in protecting the public health. Since that time, though, now we've got USP and we've got Drug Supply Chain Security Act is similar. We've got federal standards on that. So I'm wondering whether standard of care could include that. There would still be, of course, the responsibility and accountability at the level of the pharmacists who are performing those functions, and they would the enforcement for failure to follow this would still be something we would all want in place to protect our patients. But I was thinking broadly, if we're going to look at standards of care to support the practice of pharmacy in the clinical arena, should we not also look at it in those areas where there are very specific guidance documents as well as interpretations that continue to evolve to support safe practices in pharmacy? So just something for consideration.
Thank you, Dr. Shane. Tricia?
Sorry about that. I thought I had unmuted myself. So John Gray, you are unmuted.
Yes, thank you very much. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. Thanks for the opportunity to comment. Please jump in and tell me if I'm wrong. I'm providing comment on bullet number 1 under the memo under agenda number 5 related to opening up provisions of 4052.1 and 4052.2.
That's correct.
Perfect. So I think there are several provisions in existing law that would help the board to open up these provisions of 4052.1 and 4052.2 to all pharmacists. Most notably, 2021's AB 1533 added Business and Professions Code 4052A13, which was drafted to allow any pharmacist, seemingly regardless of practice setting, to initiate, adjust, or discontinue drug therapy under a collaborative practice agreement with a healthcare provider with prescriptive authority. So I think that could go a long way to achieving some of the ends that number 1 is asking about. I would suggest that there might be a couple of gaps in pharmacy law that are limiting the usefulness of this section of code, 4052A13. Specifically, Business and Professions Code 4040A1F gives the conditions under which a pharmacist issued drug order is a valid prescription. And Business and Professions Code 4051B gives the conditions under which a pharmacist may authorize the initiation of a prescription. And Business and Professions Code 4052A13 is absent currently from both of those sections of statute. So defining when a pharmacist can issue a prescription and when it's a valid prescription. So we would just suggest that the board should evaluate whether these statutes should be updated to add 4052A13 to include that as within the definition of a valid prescription and one of the conditions under which a pharmacist may issue or may I'm not going to be precise with my language, but essentially may issue a prescription. Thank you very much for the opportunity to provide comments.
Thank you, Dr. Gray.
All right. Next we have Keith Yoshisuka. And Keith, I'll let you know when you can unmute yourself. All right, Keith, you should be able to unmute yourself.
Thank you very much, Keith Yoshisuka. To the question of whether it should apply to all pharmacists, I'd like to take a page out of the medicine handbook where licensure confers authority to do certain things, but the individual physician would be required to deny or refuse to participate if they are not qualified. For example, if a dermatologist were asked to do heart surgery, you would, of course, have to decline because he's not qualified, is not trained and educated to do such things. This responsibility should also apply to pharmacists. Pharmacists would have to say, no, I'm not trained in that area and have to decline to participate. So this may be new in some areas, but is part of the responsibility of a pharmacist. If a pharmacist does not feel competent in a particular area, it's incumbent upon the pharmacist to decline. The same is true with attorneys. Attorneys, if they're not qualified to handle a case, they have to either decline the employment, associate with somebody else that is competent, or develop the competency. So I submit these comments and in addressing the issue of whether or not it should apply to all pharmacists, and I believe it should. Thank you.
All right, the next request for comment is from Stephen Gray. Stephen, you should be able to unmute yourself.
Yes, thank you very much. First of all, let me say I agree with John Gray. John Gray is, by the way, not a relative. But when AB 1533 was enacted, it did leave out some very important references, which he's mentioned already. But there's several others too. For an example, in 4060, 4076, 4111, 4174, in the Health and Safety Code regarding controlled substances under 1150, 111210, et cetera. So it's very important to go through and as we're making these changes to make appropriate references so that it's clear, for an example, that the authority under, as he mentioned, 4052A13 also it makes it a valid prescription because that can be challenged by payers it can be challenged by other entities, and we want to make sure that that's clear. I would also recommend, though, that to accomplish what earlier today was talked about in the recommendations of the board, we have to look at some of the fundamentals. Everything gets down to definitions. So I think there's going to be a need to modify language in the legislative declaration section of 4050, as well as in the definition of a pharmacist under the law, to modify those sections. And maybe that's where we start, because again, as it was mentioned earlier today, if you don't start with fundamental definitions, then there's not clarity among stakeholders and among people discussing it exactly what it is we're talking about. So I would, before we start up on the 4052s, I would start with those 4050, perhaps 4051 by itself, etc. Thank you very much.
Thank you, Dr. Gray.
All right, this is a moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia. Okay. Jesse, your hand is raised. Go ahead.
Hi, thank you, Sung. So just as a kind of follow-up, a couple of people had mentioned the sterile compounding, and I agree that should be left alone. It's my understanding, and please, anyone, including Renee, correct me if I'm wrong, that California has pretty high standards, and if not maybe higher than the national standards. So I wouldn't want to open that up for interpretation if that's going to potentially lower the standard. And then also just in regards to a comment made about a pharmacist should be essentially able to deny services if they aren't qualified. I wholeheartedly agree with that. A lot of the discussions we've had is that unfortunately pharmacists don't have the autonomy to deny that. And of course, a facility should have the right to decide what they want their pharmacist to do. But at the same time, if a pharmacist doesn't feel comfortable doing something, we want to ensure that they do have the autonomy to be able to say no if that's not something that they're comfortable with.
Thank you, Jesse. Any other thoughts before we move on to the next question? Okay, the next question. Under current law, there are specified functions that pharmacists are authorized to perform, but only pursuant to state protocols developed and or approved by other boards and or authorities. Could a transition to a more standard of care practice model to provide these services to remove barrier to access to care while ensuring patient safety? For me, I believe it is appropriate where the workplace and conditions are appropriate, again, to support such activities. Nicole, your hand is raised.
Yes, hi. I think this is a great place to use a standard of care model because we've seen it before that the protocols that we have in place for furnishing become outdated. And then we're not giving the appropriate care, or we're not really using them much anymore. Because of that. So I think standard of care here makes perfect sense. Let us keep up with the data for these things. You know, I think of, we didn't put it in the example, but I think of PEP and PrEP. There's a whole bunch of new drugs in the pipeline that are going to come. And we want to be able to give what are the newest drugs, what are the newest things. So yes, I think in this case, it makes sense.
Thank you, Nicole. I absolutely agree. All right. Any other? Renee, go ahead.
Yeah, I just, just short comment, but yes, I mean, in terms of the part of the question about removing a barrier, I mean, to access, I think it would definitely increase access to care since the community pharmacy setting is so accessible for many.
Yep, that's
and
cool.
Their practices were expanded.
Thank you, Renee. Okay, we're ready for public comment. Moderator.
All right, I am opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or simply raise your hand. Lisa Kroon, I see your hand is raised. You should be able to unmute yourself. And you're unmuted. Lisa, you are unmuted, but we are not hearing you.
We can hear now.
Yes, we can hear now. Oh, she accidentally, I think, muted herself. We'll try this one more time. All right, Lisa, you should be able to unmute yourself.
Hi, thank you. Lisa Kroon, UCSF School of Pharmacy. Another great example of the standard of care approach, removing barriers, is our current nicotine replacement therapy statewide protocol. Chantix was not able to be included in it, and this is a first-line therapy. And so taking the standard of care approach, a pharmacist would be able to use existing, clinical practice guidelines as these get updated, as new evidence comes out. So I would be very much in favor of this standard of care approach to remove such barriers. Thank you.
Thank you, Dr. Kroon.
All right, the next request for comment is from Stephen Gray. Stephen, you should be able to unmute yourself.
Thank you. I also agree with the previous commenters that when it comes to protocols, especially statewide protocols, at best they should be guidelines that a pharmacist would be responsible for reviewing and determining what the standard of care is. That's guidelines both at the state level, at the national level with the other government agencies, but also within the profession. It's very important as we move to a standard of care model for clinical practice that the pharmacists who are involved have to recognize that there is a higher now responsibility for them to do record keeping regarding their own qualifications and maintaining their ability to provide the standard of care. Otherwise, when it's looked at retrospectively, the charge may be unprofessional conduct, for an example, for not staying up to speed and for attempting to provide a service for which the standard of care has changed. I think that's very important. As you go forward with legislation, it probably needs to be clarified, for an example, in Section 4050B, that what the intention of protocols and other things is. And there has always been kind of a tug of war whether a state adopted protocol supersedes any collaborative practice agreement protocol that has been developed, and whether that sets the standard of care, or whether what has been developed in the Collaborative Practice Act or under the hospital's policies and procedures, or even now with the advanced practice pharmacists, which don't have to have a collaborative practice agreement, which one supersedes, or do they supersede, or are they just advisory? So I think looking at that 4050B section, there may be some language there that can clarify it. Thank you.
Thank you, Dr. Gray.
Next, we have Keith Yoshizuka. Keith, you should be able to unmute yourself.
Thank you very much. I wholeheartedly endorse the concept of migration to a standard of care model. In our discussions with Governor Newsom, he himself apologized for taking so long to issue some emergency waivers, particularly in terms of allowing pharmacists to do COVID testing in the early days of the pandemic before there was such a vaccine. It took months before this was enacted. And during those months, who knows how many other people could have been screened and identified as being COVID positive had pharmacists been able to act. And it's absolutely within our scope of practice to do so. So I encourage the board to proceed with this model. Thank you.
Thank you, Dr. Yoshizuka.
All right, our next request for comment is from Daniel Robinson. Daniel, you should be able to unmute yourself.
Thank you. Regarding other agencies sort of defining the practice of pharmacy, I just want to point out that under the Business Professions Code 2725E, nursing scope of regulations, it does say that no state agency other than the board may define or interpret the practice of nursing for those licensed pursuant to the provision of this chapter. Similar language exists in the for respiratory therapy as well. And if you were to look at the Medical Practice Act, which is a guidance document that is used by medical boards. It does state that the Medical Practice Act should not apply to those practicing dentistry, nursing, optometry, psychology, or any other healing art. Indicating that we've got the medical board that's involved in sort of regulating what pharmacists are doing and creating, it's actually written into our statutes. And I think we need to, be upfront and make sure that we are defining the practice of pharmacy as pharmacy and on behalf of the state board. So thank you.
Thank you, Dr. Robinson.
All right. Next, we have Andre Pieters. Andre, you should be able to unmute yourself.
Hi, good morning. I would like to add, first of all, that I think any scope of practice of a pharmacist conversation must include scope of practice for a pharmacy technician. We all know that there has been a movement, and the movement is accelerating to move pharmacists away from being product focused to be patient care focused and clinical focus. And the question will then become, what are we going to do to backfill some of the pharmacist functions that are progressing? And I think pharmacy technician and their qualification and scope of practice could ultimately help support some of the product and getting product to patients focus, just some of that manual work. In addition, I'm going to ask for another opportunity to discuss a little bit more about my experience in pharmacist scope of practice. But I don't think this current 3-minute piece that I'm in is going to be enough for it. So I'm going to stop for right now, and I'll request another 3 minutes to maybe share some of what I have to say.
All right. Thank you, Andre.
And next we have Susan Bonilla. Susan, you should be able to unmute yourself.
Thank you very much. I just wanted to, as we are considering, removing these barriers to access of care, just make a supportive comment that one of the elements is, as we're contemplating this shift, is to make sure that it is fully implemented with payers, with insurance, with Medi-Cal, as we're really looking at some of the clinical services that would be available beyond just the dispensing of medication. So I just wanted to put that out there, that any willing provider provisions, that if there is payment for care, it should be extended to any willing provider. That is something that we strongly are supporting this year, and I think it is an element of this discussion as we consider the implementation of moving in this direction. Thank you.
Thank you, Susan.
All right. And now we have Andre Pieters. Andre, you should be able to unmute yourself.
Thanks for the opportunity again. My original training as a pharmacist, my original qualification was I first was a pharmacist in South Africa before embarking on an immigration journey, and the advantage I feel I have is that in South Africa, which is considered a third world country, we had the opportunity to get a great education as pharmacists. And also, there was a big focus on being a third world country, on how to provide care for communities that does not have access to modern healthcare. And part of my pharmacy school education was that we were all required to take a course in what I would loosely refer to as primary care medicine. And with that qualification, community pharmacists were able to do various things along primary care and caring for patients in community pharmacies that did not require state protocols and things like that. And so I think looking at that experience, I think the training and education that pharmacists are getting with a scientific and healthcare and biologic background, it is very easy for a pharmacist to learn some of the basics of diagnosis and care and things like performing injections, taking blood pressures, do basic assessments for just basic care like a strep throat, for example. So I feel that the scope of, I was actually surprised coming to the US how little a pharmacist can do versus what's possible for us. And I think we are limiting the pharmacists to care for patients with the current regulatory model that we're in. I think with the right training and the right qualifications, a pharmacist can do so much more. And the standard of care model would be ideally suited to take the pharmacist to a place where we can care even more for patients. And that's it for me. Thanks very much.
Thank you, Andre.
All right, this is a moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia. All right, with that, any other thoughts, members, before moving on to the next question? Jesse?
Yes, hi. So the one thing that I haven't really heard discussed for this question is the part which asks how we can still ensure patient safety. And that's the biggest concern, particularly in community chain settings, as we've seen and heard discussions about both in this meeting and also in the medication error reduction committee meetings. And so I do want to just kind of ask the questions of how we ensure patient safety is prioritized as we potentially look into expanding the scope of practice when it comes to patient care services. As we know right now, the model as it exists isn't working. Pharmacists are burnt out. All pharmacy personnel are leaving the profession, which is leaving shortages, causing closures and shortened hours across corporate pharmacies and across the nation. So I just want to make sure that we're actually considering that and having more discussions moving forward about how we actually ensure a baseline, particularly when considering that standard of care enforcement models is a reactive model. And so in this discussion, I just want to make sure that we also have the discussion of how we potentially fix the current model to ensure that there's certain working conditions in place to accommodate for expanded patient care services.
Great point. Great point. Any other thoughts? All right, we're going to move on to the next question. Question 3, are there opportunities to simplify pharmacist authority related to dispensing functions? Should pharmacists have authority to complete missing information on a prescription? To me, the answer is, I'm not trying to be simple. Obviously, it's not yes or no question, but I feel like it's more yes to me. As we discussed and received comments, patients could be negatively impacted by delays when a pharmacist must clarify missing information that could be not trivial, that pharmacists could use their education to complete. But of course, there are also other sides of the story. Understand that, it's better to confirm as a pharmacist role as a double checker. So it's not an easy question, but I think we need to move on that direction. With that, I see which one was Nicole? Go ahead, Nicole.
Yeah, I think pharmacists should be able to complete the information. Obviously, only if they feel comfortable and feel that they have have what they need to do it. I think we've all been in the situation. It's a Friday night, it's a holiday weekend, it's an antibiotic, and they didn't put a quantity on it, or something like that that you can easily discern, or at least start a patient on something and then contact the doctor after, but not delay the patient. So I think this is really in the best interest of patient care, obviously with some safety parameters included.
Right, like Macobid, right? Macobid, and then or Macodantin, and then Macodantin comes with one BID. I'm sure we've all seen it. Jesse, go ahead.
Yeah, I agree. I'm sure, of course, it depends on the situation, but I just think in situations similar to what Nicole was saying, I've had patients who come here from another state, for example. They may not have insurance yet, or they're trying to find a doctor, and there's months-long waiting periods to even see a doctor. Granted, telehealth is making that more easy, but not everyone can afford it. So you think of situations in which patients have been on a medication for years and years and years, and you can see their profile, and yet they're not able to get their medication because they have to wait for a doctor. So I think in certain scenarios, it would be nice for pharmacists to have the flexibility. But of course, I would want to make sure that there are safeguards in place to ensure that we're not just changing things that a doctor may not necessarily agree with without speaking to them. So for example, maybe they prefer to have a patient on a brand name medication, but it's too expensive for the patient. Rather than changing it without contacting them, in that situation, it may be appropriate to reach out to a doctor. So I think there is room for flexibility, and it's going to take a pretty long, robust discussion to figure out exactly what that looks like moving forward.
Right. I think Maria brought up last time, these things can't be used as a convenience. It should be about, patient safety and taking care of the patient, but can't just be used as a convenience or being lazy. Obviously, I'm not saying pharmacists are being lazy at all, but just as a discussion point. All right, with that, any other thoughts? Okay, we're moving on to public comment.
Thank you, Mr. Chair. I am opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. We'll give you a moment. All right, I have Stephen Gray with a request for comment. And Stephen, you should be able to unmute yourself.
Thank you again. I agree that there are plenty of examples in the current statutes and in the regulations that things could be simplified, and that some of the regulations, even that are still on the books, are more limiting than the statutes would otherwise allow. And it's just been the Board of Pharmacy here, and the staff Board of Pharmacy knows what a problem it is to change regulations. So there's been a reluctance to go back and change the regulations to reflect more of the appropriateness that we've worked with some of the statutes. But we need to be very careful, and we need to consider when we do this, what could be the adverse impact, of other entities, including the federal government under Medicare Part D, Medicaid, et cetera. A good example is when California gave the pharmacist the ability to do emergency refills. There were payers that would not pay for those emergency refills because they did not believe it was appropriate for pharmacists to be given that authorization. On the other hand, it could go the other way. So for an example, there's a statute that limits a pharmacist's ability to do a biosimilar substitution or to dispense a 90-day supply instead of a 100-day supply on regular chronic care medication. Even though patients have a 100-day drug supply benefit, which was what that authority was all about in the first place for the benefit of patients and to increase, the compliance with the medication regimen. So we need to go through these and we need to discuss which ones should be eliminated because they are unfortunate limitations and which ones should be retained to make it clear that pharmacists in California have these authorities and abilities, which probably in many, many other states they don't have. And so payers, federal government, et cetera, may be making some adverse decisions to patient safety and to patient access. And I want to speak about patient access. Yes, the Board of Pharmacy has the authority to make sure that patients are safe and safety, but the law should be changed to make sure that that includes the Board of Pharmacy has the authority to also regulate reasonably that patients have access to pharmacist services. And just stating that in the fundamental principles of the Board of Pharmacy's authority would be very, very important and would go a long way to justifying, as CEO Bonilla indicated, that payers have to pay attention to what pharmacists can do under their scope of practice. Thank you.
All right, and I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you so much. All right, moving on to the next question. Question 4. Should pharmacists have the authority to furnish medications that do not require diagnosis or are preventative in nature? For me, when we consider health equity, access to care, coupled with shortages in primary care physician to be, this is absolutely yes. Again, not to be simple, there's always caveats, but I would say yes. With that, members, any thoughts? Jesse, go ahead.
Hi, when you say yes, are you referring to like patients who have been on medication for chronic conditions and their doses haven't changed and that sort of thing? Or are there like specific examples?
I think this is more looking at something that's more simple and not looking at like diagnosis. Does not require diagnosis. So I'm like trying to think of an example, had it in my head, but escaped right now.
Well, I can think of like EpiPen, for example. You could probably, I would say reasonably, pharmacists could probably furnish that. But I also probably would agree that if someone has an established diagnosis of hyperlipidemia, for example, and they've been on the same dose of Crestor for 10 years, that it would potentially be reasonable for pharmacists to do a refill if they can't get into the doctor's office. But I'm just curious on where I guess we draw the line on requiring a diagnosis. Does that mean an existing diagnosis? Is this just for chronic conditions? And so I'm interested to hear everyone else's thoughts on this too.
Thank you, Jesse. Maria?
I agree. I think I'm trying to figure out the scope of this and probably some real robust discussion on some specifics, because I'm thinking about all the GI medications that are out there, and perhaps don't require a diagnosis, but what's the difference between GI upset and an ulcer? It's a huge difference. So it requires some diagnostic evaluation. So I'm a little confused about how we would do this. I think the intent is great, but how to do that so the scope is what we have intended, I'm not quite sure.
Gotcha. Thank you, Maria. Any other thoughts? All right, we'll open up for public comment. Let's see what the stakeholders have to say.
All right, the Q&A panel is now available. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or you may simply raise your hand. And Rita Shane, I see you have your hand up, so you should be able to unmute yourself.
Thank you. So some examples that come to mind are a patient is started on an oral chemotherapy agent that is predicted to cause diarrhea or nausea, and the physician omits those orders. And that's kind of standard of care to provide those. Other ones are patients who are put on pain medications, opioid analgesics, and they're likely going to have constipation. So, and there are, standard compendium about how to manage these sorts of therapies and these kind of preventive measures so that the patient doesn't end up having a problem in the middle of the night and having to call a provider for something that that the pharmacist could provide them as part of the care of the patient. So often, and at least in our practice setting, we see physicians are so busy that they may leave off things that are actually intended to be part of the treatment plan, whether it's in the acute care space or at discharge, but that we then have to call for. And instead of just making sure that the order and what is needed to go with the order is complete.
Thank you, Dr. Shane.
Next, we have a request for comment from Stephen Gray. And Stephen, you should be able to unmute yourself.
Yes, I totally agree with Dr. Shane and with the previous comments. The basis of SB 493 in 2013 were all of the medications that were listed there were prescription medications for which a diagnosis was not needed. They were self-diagnosed by the patient. The physician doesn't tell the patient, where they're going to go for vacation, and therefore what vaccinations they need, etc. So it is, but it's very important to say that pharmacists already have the ability to recommend to patients OTC medications for which there is no, patients can use those on their own knowledge and ability, presumptively under FDA federal law. That's what the labeling is all about. So what we're really talking about here is prescription medications. And there are prescription antidiarrheals and there are OTC antidiarrheals. Likewise, there are various things. So it's very important we look at this in the context of prescription medications, including certain controlled substances and so forth. And once again, we have to look at this as, yes, you may grant that ability, but it may or may not be covered. And that's something probably the Board of Pharmacy doesn't have control over. So there are better choices, for example, for pain medication that are not covered under a lot of benefits, and because they are OTC. So this needs to be looked at very carefully, but in general, I agree with this completely. Thank you.
Thank you, Dr. Gray.
And next we have comment from Andre Pieters. Andre, you're unmuted.
Thank you. And I agree that a pharmacist should be able to give preventative medication. And also to add, when I think of preventative medication, I think about contraception. I think about travel medications, vaccinations, perhaps a patient going to an area where there's malaria, so preventative for that. More recently, we've seen medication for COVID prophylaxis, and we're all aware of HIV PrEP therapy. And it could be something as basic, to add to what has been said earlier. It could be something as basic as preventing constipation and that sort of thing also. Thank you.
Thank you, Andre.
All right, I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you. Thank you for the comments. All right. Before moving up, Jessie, your hand is raised. So go ahead, Jessie.
Hi, thank you, President O. I appreciated the public comment, in specific, the mention of potentially furnishing medications that were omitted as part of a set order. I can think of times where I've had patients who I received a batch of antibiotics, and it's very clear that they have H. pylori, but the doctor forgot to prescribe a PPI. So especially in cases where it's after orders, I already know based on what the antibiotics were prescribed and the dosing what PPI they should need and what the dose should be. So I can think of situations like that in which a pharmacist could potentially have the authority to kind of furnish for any missing medications that were part of a group order. And I think that's an interesting and good point there.
Thank you, Jesse. Nicole?
Yeah, I definitely agree with the concept overall, and there was a lot of great examples. Thank you, Dr. Shane. That was really helpful for me. I think where I get a little stuck is there's going to be certain cases where the pharmacist has to have knowledge of that area to do it. One thing that comes to mind for me is the potential for post-exposure prophylaxis, but not for HIV, for other sexually transmitted infections. You can sometimes take, a dose of antibiotics prophylactically, but there should still be some follow-up testing there. There should still be some medical care. So, and you'd have to have that kind of knowledge. So I like the concept, but there's going to have to be some limitations, I think, or parameters under which it falls. Then I can't fully articulate what those are yet. So I think I need more, but yes, it's a yes, but is my answer.
Great point, Nicole. And I think, but that's where, in my head, I think where we want to try to go to some standard of care where you would hope that pharmacist would be able to say, Nicole, I'm so sorry. I don't know well enough. I don't think that I really would be able to provide that service. I think that that's kind of the vision. I could be off base here, but I think that's kind of where we are trying to see, leave it up to the pharmacist. Can they make those, within their knowledge, skills, and abilities to provide that services? And instead of us saying that you have to have this, you have to have one number of CE on this topic and do this, and then you can do that. I'm just hoping that, opens it up a little bit more for pharmacists to be able to, take action on those situations. But much more to discuss. I see someone's hand raised, but go ahead, Nicole.
I was going to say, yeah, I totally agree with you. I think where this gets tricky is to the point that Jesse has made in the past. If you go to one location of a corporate chain and they can provide the service, and then you go to another and they can't, or when that one pharmacist isn't there, they can't, that's where we're going to run into some things. But I definitely love the concept overall.
Right. Yep. Tricia, I'm going to allow the moderator. Go ahead and open up for public comment.
Okay, sure. Let me go ahead and open up the panel real quick. All right, so the Q&A panel's open, and of course, people can just raise their hand. And I see, Rita, you have your hand up. You should be able to unmute yourself.
So sorry, I'm really appreciating this conversation. I think what we're hearing, again, sorry for all my comments. I feel really passionate and agree with all of the discussion. I think we're evolving it to have a framework for standard of care. So this issue of a pharmacist who may not feel comfortable, and as Dr. O expressed, different venues or different approaches to how that may happen. It's as this evolves in terms of what is a competency, that's probably a later topic, and I have some thoughts about that. But at the local level, whatever that local organizational level is, whether it be corporate or a health system or a pharmacy, there will be certain services that will be part of the portfolio that are provided in that pharmacy. And where the way I think about it, because I always think about how do you operationalize something like this, because certainly we've all had to do that in our practice settings. In that setting, the PIC in collaboration with the appropriate stakeholders and leadership would determine that based on the needs of the patients being served, the resources, et cetera, the scope of services that would be under the standard of care within that organization would include different aspects of care, including clarification of orders, or I think was it adaptation of orders that Idaho said, as well as maybe some specific services. So for example, a pharmacy may decide to do diabetes management, hypertension, or vaccination. Another pharmacy may not. They may decide it's a different scope or different types of services. So for the scope of services that are provided, the pharmacist would then be evaluated and educated to use standard of care in those services. That's kind of where I think we're evolving to, and there's obviously a lot more discussion before we get to the end of this or to the decision making that all of you are engaged in with us. But I could kind of see that being the way this could evolve, and allowing some flexibility for a specific patient. So if a specific patient was identified as needing a need based on the pharmacist's knowledge, just like you described the patient that you just know has H. pylori, the pharmacist would then, within the standard of care for that condition, based on current compendium or current guidelines, then ensure that first and foremost, the safety of that patient and the optimization of the medication is taken care of. So I hope that made some sense. Thank you.
Thank you, Dr. Shane.
All right. Our next request for comment is from Stephen Gray. Stephen, you should be able to unmute yourself.
Thank you again. This is a very important question, and it's something that maybe a little clarification. I agree completely with Dr. Shane said, and in the hospital environment, under the current law, which has existed for over 30 years, it's completely up to the hospital what orders for prescription and non-prescription medication can be ordered by each pharmacist. In other words, if you look at that, there are no postgraduate education requirements in law, but the hospital can decide which pharmacists have the privilege to initiate orders for hospital-administered medication and which ones do not. And we have plenty of practice in California where that has increased the safety of patients. It's prevented, especially as she indicated, errors of omission from prescribers and has greatly improved the quality of care. I'd also like to point out in the question of number 4, the term furnish is used, authority to furnish medications. That word was particularly used in SB 493 in 2013 and was differentiated from initiate or prescribe. Let me say that again. The word furnish under the law adopted in SB 493 did not mean initiate or prescribe. And that has caused a lot of confusion because the word furnish under nurse practitioner law does mean to prescribe, if you go back and look at the definition of a prescription. So the Board of Pharmacy should take on the issue of, does that need to be clarified? Does that need to be changed? How does that affect? Because that has caused a lot of confusion. But the differential was worked out with the Medical Association and the Medical Board of California, and that is why we were able to pass SB 493 without their objections, and likewise for the Nursing Board. So be careful under this, what you're really trying to do, and let's take the opportunity to clarify it. Thank you.
Thank you, Dr. Gray.
All right, this is the moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you. All right, with that, we're ready to move on. All right, next question is, I think there's a typo. I think it's, should pharmacists have the authority to furnish medications for minor non-chronic health conditions such as pink eye, lice, ringworm? Yeah, it's probably not in the slides. It's question 5. Should pharmacists have the authority to furnish medications for minor non-chronic health conditions such as pink eye, lice, ringworm, etc.? So I think I would hope that this could get tricky, but I'm just gonna say, I think one of the interesting thing is, bringing different ideas. I know that pharmacists in Canada have ability to prescribe medications for pink eye, acid reflux, cold sores, skin irritation, menstrual cramps, hemorrhoids, impetigo, insect bites, hives, hay fever, and sprains. Also, they're able to treat uncomplicated UTI and prescribe antibiotics after tick bites to prevent Lyme disease. I understand being specific again. I kind of think maybe going off track of standard of care idea, but also maybe there are challenges with, opening up so far. So just interesting thoughts here, and I will start with Jesse. Jesse, go ahead.
Thank you. So, like so many people said before earlier in the discussion, I think the biggest barrier with all of these things is going to be insurance reimbursement. A lot of the conditions listed in the examples, like ringworm, etc., a lot of them could potentially be over-the-counter medications, in which case it's not normally covered anyway. But I absolutely agree there is an opportunity to expand, like urinary tract infection for acute uncomplicated UTI, rather than making someone who's already clearly in pain and uncomfortable wait at a doctor's office for who knows how long to get that medication. Pink eye is another example. And I agree, cold sores, these are pretty simple conditions that we could potentially do acute furnishing of, as long as there's sufficient baseline working conditions that would make it safe for patients to get.
Thank you, Jesse. Nicole?
Yeah, I generally agree with this as well. I think one thing that came to mind for me, though, was the potential need to examine a patient in some way. The one that came to mind for me was ringworm as an example. If the patient wants to show you something, they don't know that they have ringworm and they want to show you, that could be a little bit problematic. If it's not, if it's on their arm, that's pretty easy. If it's somewhere else, that might not be appropriate for you as a pharmacist to be looking at. So that was kind of my only concern. In general, I like this. I also think there maybe needs to be the option to opt out of this. Maybe someone doesn't feel super comfortable looking at someone with the potential for pink eye or for lice. If they, have their own children, they're afraid of transmitting it, that sort of a thing. I think some pharmacists maybe won't feel comfortable doing these things. So there has to be an optional nature to it.
Thank you, Nicole. Maria?
I agree with all the comments that have been said. I think one of the things that I saw when I first read this was the topical nature of these treatments appears to be in the examples. And I'm torn between limiting it to topical, but I'm also very worried about having it go too far, because there are a lot of, antifungal oral medications that could be used to treat ringworm, or more extensive antibiotics that could be used to treat pink eye that may be going a little bit too far without more diagnosis or have other concerns. So again, I think this is very interesting. I'm more interested in what you said about what's going on in Canada. I think that is maybe a better way than, at least in this example, it seems to be only about maybe only topical, but there are some oral treatments also available that I'm not sure if we want to step into that role too. Thank you.
Thank you, Maria. All right, any other thoughts before opening up for public comment? All right, we're ready for public comment. It's question 5 on the meeting materials, yep.
All right, the Q&A panel is now available. If anyone would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or raise your hand. I do see that we have Andre Pieterse raising his hand. So Andre, you should be able to unmute.
Thank you. I'm going to go back to my what I said previously and my previous experience in a primary care environment. I would very respectfully disagree with Dr. Serpa in that I would not limit us to just topical medications. I think. If we get a baby in the pharmacy with oral thrush, then it should be as simple as using a tongue depressor and a light, and just verify that what we see is indeed that mouth infection. Also, I think it's easy to train and it's easy to diagnose, for example, issues. So let's say there's an ear infection, to use an otoscope and look into an ear and see what you can see. Some basic palpitations, just feeling in the throat area for lymph node swelling. I think if pharmacists are trained for that very basic kind of diagnostic procedures, and they're competent and experienced in it, that it should be within the scope of practice to be able to treat some of these very basic but very common infections, where you usually need to go and visit an urgent care, and in the absence of that, an ER to get a prescription medication for that. Thank you.
Thank you for the comments, Andre.
All right, next we have Stephen Gray. Stephen, you should be able to unmute.
Thank you again. This question has that word furnish in it, which needs, in my opinion, needs to be clarified going forward. I think this is a very important area to fully discuss. For one, as mentioned, it's going to, if it includes OTC medications, there may be issues of coverage, but that doesn't necessarily mean that the pharmacist shouldn't have a role here. The patient may be very willing to pay for the medication or may have some other way to get reimbursed, and they want the advice of a pharmacist. To me, the issue becomes, is the pharmacist then issuing or prescribing in concept, and therefore it must require all the standard of care. There's an issue with they don't have the information. Well, what information are you talking about? They have the information about the drug. They have the information about how the patient presented. They have the information at hand, but under the standard of care, they may not have enough information to do it appropriately because they don't have the patient's complete medical record. They don't have some of the lab reports, etc. It was mentioned about Canada. We got to be careful about Canada. It's different just in Canada among the provinces as it is in the United States among the states. British Columbia has a database for everything that is dispensed to all of its patients, not just controlled substances that the pharmacists have access to. That doesn't exist in California or any other state that I know of, but a lot of pharmacists do have access to the patient's complete medical record. And so therefore, that's part of the decision they could make using the standard of care. So we need to be very careful about it. The other thing that should pharmacists have the ability to say no? Actually, yes. But on the other hand, should they be recommending something for ringworm or lice without taking a look at it? Physicians, nurse practitioners, and others are also concerned about spreading things to their children, but they wear gloves and they wear masks and they do things to make sure that they're fully able to assess the patients. And then finally, it's a look about liability. When a prescription is issued, the liability is upon the prescriber, it's upon the pharmacy that is dispensed if it's even if it's a OTC medication. So what's the liability question here that needs to be discussed? A pharmacy operator, whether it's owned by a pharmacist or a corporation or a hospital, they may decide that their pharmacists are not able to do this because they don't want to assume the liability for all of their pharmacists. And lastly, it's been mentioned that the payers would still have the right to credential pharmacists.
10 seconds.
They're going to cover it. So don't forget that you can't take away the payer's right, including Medi-Cal, to credential the pharmacist on an individual basis. Thank you.
Thank you, Dr. Gray.
Next, we have Susan Bonilla. Susan, you should be able to unmute yourself.
Thank you very much. I know we're having a rather wide-ranging discussion here, and I'm sure we'll continue. But I did just want to mention that there probably is an opportunity as we look at SB 409, the sponsored bill by the board last year around CLIA-waived testing, as we're talking about some of the issues that have been raised, to take a look at 409 and see if that doesn't also provide some natural progression that we should be considering as part of this discussion when we're talking about not just testing, but then also treatment that could happen with, of course, proper communication and follow through. Thank you.
Thank you, Susan.
All right, I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia.
Welcome.
Maria, go ahead. Thank you.
Hi, thank you. I just wanted to clarify my comments. I was not against oral therapies. I just think that should we include oral therapies, it didn't seem to be obvious in the question that we were being discussed, but should we include it, that further discussion be had, because it does add more complexity. You know, the example that was given about oral thrush doesn't, you know, and nystatin and, you know, some simple things I think would be fine, but would we go to some really extensive antifungal medications on a baby on our own? I probably would be hesitant to do that. Doesn't mean that there aren't some simple oral therapies, but I was not adverse to oral therapy. Thank you.
Thank you, Maria. And I think that's going to be the challenge for the discussion moving forward. Also, is that once we start bringing up these real world scenarios, are we going to say, oh, that's fine, that's not okay, that's okay, this is fine? I think that we could have lists of 2,000 things there that we're going to be like, oh, you know, what do we do with it? So I just, you know, I'm aware of it. We're all probably aware of that possibility of how to deal with that. Jessie?
Thank you. The one comment I want to make is, you know, the example of a baby with oral thrush, probably easy to figure out right away what they would need, the oral nystatin. But I will just say that I would be extremely hesitant expanding it to pediatrics just yet for a lot of things. Granted, lice could probably be simple, but particularly when it comes to not just recommending something over the counter. I think as a baby step, it makes more sense to maybe start with adults before going to pediatrics.
Yep, I agree with you, Jessie. All right, we're ready to move on to the next question. I think that is question number 6. Oh, Dr. Shane has raised her hand. I'll let her speak. Go ahead, Dr. Shane. Oh, sorry, Tricia.
Yep, that's okay.
So I just I wanted to reflect on Dr. Daniel Robinson's questions that would serve as a basis of guiding principles to actually make these sorts of decisions with respect to not 200 doctors. So I totally agree with you. We can't go down that pathway. We'll never. That would be really, really difficult. But my thought is that collectively there are probably a set of guiding principles to help support what should be part of standard of care and what really does require collaboration and deeper knowledge and or understanding of the patient's overall condition. So I just wanted to, and I know the board members have seen this, but the list of 8 questions that Dr. Robinson posed is actually a very useful basis for starting this kind of guiding principle document, which might be the way to approach something like this going forward. Thank you.
Thank you, Dr. Shane. All right, going to next question, question 6. Should pharmacists have the authority to furnish medications for which a CLIA wave test provides diagnosis and the treatment is limited in duration? Examples are flu, COVID, strep throat. For me, I believe the answer is yes. It is best interest of patients who may not otherwise have access to care or who require immediate access to care, especially in instances where treatment must be started within a short duration after symptom onset. Another caveat, though, obviously, is the big word, you know, reimbursement, as well as can pharmacists really be able to provide these services in current working conditions. So with those caveats, I'll open up for members to member comments. Jessie?
Thank you. I totally agree with everything you said, President O. Particularly, you know, if pharmacists are performing tests, they should ultimately be able to furnish the treatment for it. If you know that someone has a flu diagnosis and their symptoms started today, you should be able to furnish and dispense them the Tamiflu so that they don't have to go to a doctor's office and go through that whole process. And hopefully moving forward, we see if the discussion of reimbursement is even a feasible thing and something that we have the authority to implement in some sort of model. But if you're doing these acute diagnostic tests, I do think that it just kind of goes hand in hand to be able to provide the treatment for it.
Thank you, Jesse. Any other thoughts before I open up for public comment? All right, we are ready for public comment.
All right, I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or you may simply raise your hand. We'll give you a moment. All right, I see Stephen Gray would like to make a comment. Stephen, you should be able to unmute yourselves.
Thank you. Yes, I believe the answer to this question is yes. I think it's very important to understand that it shouldn't be limited to just CLIA-waived tests. It should be any test that, for an example, that the patient could do for themselves, whether it falls under that category or not, a pharmacist should be able to do. And in fact, there are already payer entities that are willing to pay for the analysis of test results, the expertise that the pharmacist provides, as long as there is a record, a contemporary record made of that service that is subject to audit afterwards. And so that is already starting to be picked up by a lot of private and government payers across the country. They want, just like they could audit prescriptions, they want to audit the record. Show me that you actually did get the test results and what your analysis was and why you chose that particular treatment modality and so forth. So I use this question to go along with the idea that the Board of Pharmacy may have to educate or maybe even initially put in some requirements about what type of clinical records must be kept by the pharmacist, whether they're in a pharmacy, whether they're in a institution that does not keep records, like maybe a hospital does, but clinics don't necessarily. So those records of what the pharmacist did physically, mentally, and so forth, the basis of their analysis would be records that the Board of Pharmacy would look at after the fact if there was a complaint of treatment, of negligence, of incompetence, and those records should be subject to review by the Board of Pharmacy. So record keeping about your standard of care process, you don't guarantee an outcome that it's going to cure, but you should be responsible for going through the right process before you made the decision to initiate therapy officially. Thank you.
Thank you, Dr. Gray.
All right, I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia. All right, any other thoughts before we move on to the next question? Okay, moving along, we're almost there. Question number 7, should pharmacists have the authority to order and interpret drug therapy related tests as opposed to current authority limited to only ordering and interpreting tests for purposes of monitoring and managing the efficacy and toxicity of drug therapy? I believe strongly that yes, that there has to be pharmacists who have the authority to order and interpret any drug therapy-related test if it is necessary for evaluating or patient care. Members, thoughts? Nicole?
I actually could use some examples. I was having a little trouble figuring out where this might be used. So if there's an example, that would be helpful.
Sure. I'm going to let Anne speak on this because I think she has some very close experiences and why we're forming this question. Sorry, didn't mean to put you on the spot, Anne.
So as totally the non-pharmacist here, I don't know I'm the best person, but I think, Nicole, maybe one of the good examples might be HIV PEP and PrEP. So right now, CDC guidelines suggest, that pharmacists or that, perhaps some testing might be appropriate in advance, but the law specifically states that pharmacists are only to counsel them potentially on doing those kinds of tests. And because they have not started the therapy, if you will, you can't use the authority that they are managing it consistent with the law right now because they haven't actually started it. So I don't know if that's a very good example, but that's the one that I can come up with. Sorry about that.
Yes, no, that was exactly what I needed, what the difference was between the two. And yes, I should have thought of the HIV example. So thank you very much, Anne. That was helpful.
Thank you, Anne. All right, Maria?
Hi, it's my understanding we currently have this authority for the purposes of monitoring and managing efficacy and toxicity of drug therapy. So it's pretty expansive. I know that there are pharmacists out there who are ordering renal panels and hepatic panels, monitoring for toxicity. So it's not just drug levels, also monitoring maybe white blood cells or hematocrit if you're worried about anemia as a toxicity of the drug therapy. So it's pretty expansive now. I'm not quite sure what more we would add unless I'm missing something.
Thank you, Maria.
Can I just
go ahead?
I don't know that I articulated very well. So, Maria, I think some of those are for managing therapy that you're already on, but there might be times where you might need to order a test to start the therapy. And so I think it's intent. Sorry that I'm totally botching this. Nicole, save me, but because I'm not doing it right. But
I think there's a lot of legal subtleties that it took me a little while to understand. So
yeah, in the HIV example is perfect because for PrEP, there's like a whole set of labs that you're supposed to do at the beginning, every 3 to 6 months, depending on the parameters of the person. But you're supposed to do these tests before you start, not just for monitoring, but before you start the therapy and to make sure the therapy is appropriate. And that is like a perfect example. And yes, I get the difference now that you need those before you're starting and you're not just monitoring something that has already been started. So if we're going to furnish things and there needs to be labs before you start furnishing, this would kind of allow that potentially.
Does that help, Maria?
Not really, I guess, because in my world, we do that already. If someone's starting on Coumadin, we do some baseline labs before we start them. So
you guys might
it includes it. I'm agreeable. I think it needs to be in all situations.
Yeah, there may be just different authorities too that are being used in certain settings. Jesse?
Yeah, that's exactly what I was going to say, Sung. I think it probably depends on the setting. And I think in a clinical setting, obviously all these things are appropriate and probably already happening when you think of like warfarin monitoring, for example. And so I'm not sure, and I don't know if this will be controversial. We'll see what everyone else does through public comment, but I'm not sure how this would be necessarily appropriate or necessary in every single setting. Like how it would even be feasible for a community pharmacist, for example, to order like renal panels and then send a patient off somewhere. And then, there's a disconnect because most likely in the majority of community settings, you wouldn't be getting those tests back or how that would actually work feasibly unless you're actually within a facility that's connected to some sort of clinical service. So I'm having trouble seeing how that would apply to every single setting and that, rather than like institutional or clinical. Maybe someone else can help me visualize that.
I think it's just kind of thinking small steps just to kind of going back to the HIV PEP and PrEP. I would just I don't mean to bog down with that alone because there are probably other examples. But, it's expanding areas where it's not so limited in such as 4052.1 or 4052.2. You are allowing pharmacists to be able to order tests that is maybe a prerequisite to starting a therapy. So, but you don't want other sections of the law that would hinder that ability. So that's kind of my thought process. And Nicole, go ahead.
Yeah, thank you. I do think that HIV PrEP and PrEP is the best example. And I think of the independent pharmacy like Dr. Hopkins at Pucci's Pharmacy, who provide these kind of services in a place where there's not a lot of those services. And this kind of, so this might not apply to every big chain in LA. There's probably not going to be a huge impact, but I think of places where there's not a lot of these services available and a retail pharmacy had the ability to do it and the expertise. They're already doing a lot of HIV care. This would allow them to see the process all the way through. And there's definitely a lot of areas in the state where there's not a lot of PEP and PrEP providers, but there are pharmacies that are interested in doing the work. And this would allow them to fully open up that service. So I think this definitely makes sense. It might be somewhat limited who it applies to, but the impact on equity could be very large in certain areas.
Thank you, Nicole. Thanks for a great discussion. Going to open up for public comment. If any other thoughts, we'll probably come back after we hear some public comments. So, Tricia.
All right, I have the Q&A panel open. If anyone would like to type comment and send it to all panelists, or you may simply raise your hand. Susan Bonilla, I see your hands up, so you should be able to unmute.
Thank you so much. I really appreciated the most recent comments here about access and equity, because I think one of the things that to keep our eye on is that we're really looking forward to the next 5 and 10 years of where is the future of pharmacy going. So I don't think we want to get too bogged down in just what is possible today. But when I think of the vast number of, let's say, Medi-Cal patients who struggle immensely to get the simplest levels of care met. I just think there's incredible potential here within this profession of pharmacy when we think of the Affordable Care Act and its implementation around the affordability factor. If we have this vision for the future of really maximizing the opportunities for access for patients throughout California. And I do think that is what will achieve more equitable healthcare access is the provisions that we are discussing today. So I just wanted to give my strong support. And while everyone might not be set up in, today or tomorrow, next year, as we look to the future and where we need healthcare to go. I am certainly in support of what has been discussed thus far. Thank you.
All right. The next request for comment is from Stephen Gray. Stephen, you should be able to unmute.
Thank you. I think from the discussion we've heard on this particular question, it's obvious that there needs to be at least a clarification. And I would say that the answer to this question is absolutely yes. If we're going to a standard of care approach, it begins with the pharmacist's responsibility to make sure the patient has the right drug for that patient in the right dose and everything. How can they do that if they can't, when necessary, order a test or order some type of evaluation, even if it's not a laboratory test? But I think this patient should be seen by a psychologist or some other type of test, an X-ray test for osteoporosis, things of that nature. And the current language has given a lot of people the impression it's only, like you said, after the medication is being consumed or administered and you're monitoring it thereafter. It all begins with making sure it's the right medication and the right dose in the first place. And in fact, even pharmacists in many organizations that did not have collaborative practice authority, they had under the current law for traditionally and for at least decades, they had the ability to make recommendations on therapy. So they would interview a patient, they would talk about some of the side effects and so forth that they're going through, and then they would contact the patient's physician prescriber and say, well, I think you ought to start this medication. They've got severe diarrhea or severe this or that or the other. And where they apparently have an infection, a sinusitis. And the physicians had said, well, did you order the test? Well, no, because it says you haven't given the medication yet. And so the physicians and others were actually upset. They don't get paid for ordering a test. And they want these pharmacists to not only order it, but interpret it and base their recommendations on something as objective as a test when it's indicated. So I think it should be made very clear under the standard of practice that all pharmacists should have the authority to order tests if they're going to either make a prescribing or furnishing decision on their own, or they're going to make a recommendation. Well, when the standard of care would require that before anybody acts on their recommendation, there should have been an examination, a test, and evaluation made. Thank you. Oh, and by the way, excuse me for adding, in some other states, I'll give you an example of Colorado. It is quite common there in Colorado for pharmacists to be the one that have to order the DNA test, to order the pharmacogenomics test before the physicians are even allowed to prescribe that in certain organizations, and that's starting to spread.
10 seconds.
Because they know the pharmacist is the one most educated on that subject. Thank you.
Thank you, Dr. Gray.
All right, our next request for comment is from Mark Johnson. Mark, you should be able to unmute yourself.
Johnson, CVS Health. I've really enjoyed all of the conversations and all of the expanded practice talks today. Personally, and CVS Health are strong supporters of expanded pharmacist practice. As far as this testing ability in California goes, I really appreciate that this is finally on an agenda to address for the HIV issue. That this has kept us from rolling our program out in California since the inception, because we cannot order these tests, which I've well documented in meetings before. I do have in writing from the Board of Pharmacy that the current restriction in statute is just in conjunction with therapy, not prior to therapy, as we've discussed today. So it's very important to change this statute. But also I'll mention that the great advancement in California law to allow pharmacists to perform CLIA-waived tests last year is of little practical value without the ability to order the test. Now, federally, the system is set up that there is no order required for a CLIA-waived test, but practically a third-party payer will not pay for it without an order. And without the pharmacist ability to order the test, sure, you might be able to charge a cash-paying customer. There may even be an arrangement with third party in a capitated program, but we are stuck in a system of billing per incident. And on Epic, the system that's used to bill, there is a required field for who ordered the test. And in the absence of an order, really the CLIA-waived allowance in California isn't a practical allowance. So I definitely, beg the board to please give the pharmacist the ability to order CLIA-waived tests, as well as tests prior to HIV. And I think a simple striking in statute of the phrase that requires it pursuant to existing therapy would be a simple solution for all. Thank you very much for discussing this important topic.
Thank you, Mark.
All right, this is the moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia. All right, members, any other thoughts before we move on to the next question? Thank you. All right, next question. Where a pharmacist is practicing outside of a pharmacy, what requirements are necessary for records and the board's ability to inspect such practices? So I personally think that ability to inspect any location where pharmacists practicing is important, and any records should be available to the board. But I was just thinking like medical record keeping for physicians and whatnot, and I'm not sure what their requirements are, so I just wanted to also throw that out there if anyone knows, because I couldn't find much on it. And so just kind of wondering what should be the requirements here. Maria, go ahead.
I agree with the concept that, the individuals must have records and must be readily retrievable. Where I struggle with is how they share those records to provide the greater patient medical record, like you mentioned. And I'm sure there are physicians in other practice settings that struggle with that too. If they're not part of an organization with a general medical record, then there is no record of their added medications or added treatments. And, pharmacists are now going to be a part of that. One thing that I know some organizations do, I'm not sure how well this could be done in a global process, is, typically you would think that there is a primary care provider for every person. I mean, typically, ideally, and then that person would be reported. So like in a hospital setting, when a patient is discharged, the discharge records are sent or notified to the primary care provider. So they're notified of a hospitalization. Similarly, there are some pharmacists who are providing Coumadin therapy, for example. They provide updates to the primary care physician on the progress and the treatment, especially if they're discontinuing therapy, to let them know that they've discontinued therapy. To the primary care provider, that also seems like a real pie in the sky ideal. The practicalities of how to do that, I'm not sure. But limited to question number 8 about should the pharmacist doing these functions have records? Obviously, yes. And should they be accessible and retrievable at all times for the board to inspect? Yes. The third part, which is not part of the question, is how do all providers of care know what's going on for their patient? And we're talking about universal medical records, which is an ongoing discussion. Thank you.
Thank you, Maria. Great thoughts. Anyone else? All right, we're ready for public comment.
All right, I am opening up the Q&A. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. We'll give you a moment. All right, I see Stephen Gray would like to make a comment. And Stephen, you should be able to unmute yourself.
Thank you very much. This is a very important section and has been very important for many years, and there are cases involving it. But it's important to note that the question is not about whether the pharmacist has access to these records, but whether the records are accessible to the board's ability to inspect such practice. Okay, so California law is special for pharmacies. There are something like 7 or 8 sections of the statute, whether it be the Business and Professions Code or even the Health and Safety Code 11161.6 and Regulation 1707, that basically recognize any authorized officer of the law access to pharmacy records. Now, when those were put in the law, it was all about preventing diversion. And the records that they were talking about were access to records of receipt and records of disposition of drugs. And then later, pharmacies started to have to keep a profile. And coincidentally, they happened to keep the patient's vaccination records or their allergy records or their other comments that are more like medical records. They kept it in the patient profile right along with the prescription records. So there has been problems, I can tell you, about pharmacists working with medical practice groups and others, even hospitals, where they did not want the Board of Pharmacy Inspectors to have the very unusual authority of just walking in and demanding access to records without a subpoena, without a search warrant, without even patient's permission. And so they refuse to let those pharmacists have access to the general medical record or to document what they did and why they did it in a general medical record. So I believe that that doesn't hinder, though, the medical board from getting access. They just have to issue an inspection subpoena or cinch warrant, or go after other ways to get at patient privacy information. So the Board of Pharmacy would still have access to those. This is a question about how they would have access, when they would have access, and what the requirements were. And it's a lot about patient privacy, of course. So I don't believe that going to a standard of care model should reduce the requirement for pharmacists to keep complete, adequate records of what they and what evaluations they made and why and how they made their decisions and all those other clinical records. But perhaps the law should recognize that the Board of Pharmacy's unlimited immediate access to all
10
those
seconds.
records should be matched with what the medical board and other licensing agencies have to go through to get to those records. Thank you.
Thank you,
All
Dr.
right.
Gray.
This is the moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia.
Welcome.
All right, thank you everyone for the comments. Members, before we go, just wanted to survey if anyone would like to recommend any actions at this time to the board related to this discussion about inclusion in the report to the legislatures, and also just opening up for any other global comments before we go. Not hearing anything, so I'll take that as a yes. I see a public comment, so we'll allow that for one more time for global just discussion about what we
Okay.
discussed.
Andre Pieterse, you should be able to unmute yourself.
Thank you. I would like to recommend going forward in conversations regarding pharmacy scope of practice that we also include a pharmacy technician scope of practice in that conversation. Thank you.
Thank you for the comments, Andre.
All right. I see no further requests for comment. Shall I close the Q&A?
Yes, please. Thank you, Tricia.
You're welcome.
All right, Jesse.
Hi, I think for now, as we talk about scope of practice, we should really focus on pharmacists first, and then we can have that discussion maybe further down the line personally. That's just my one note there.
Thank you, Jesse. All right, we're almost there. So thank you, everyone. I hope to see you at our next and most likely last Standard of Care Ad Hoc Committee meeting scheduled for May 3rd of 2023. We'll have an updated draft of the report with all the comments and suggestions, as well as possible language maybe that we could see if we can present, and we'll go from there. So thank you everyone for all the time and effort you put in. Thank you to all the stakeholders for your participation. I really appreciate it. So the meeting is adjourned. Thank you and see you all next week.
Thank you. Bye.
Bye.